So very quickly, I'm going to introduce our keynote speaker for today. He's a very venerable gentleman, Professor Khama Rogo, somebody that we all look up to in the health sector. He's currently the lead in healthcare at the World Bank. Welcome, Professor.
Good morning, everybody. Thank you for the organizers for asking me to make a few remarks at the beginning of this convention. Can you hear me at the back? I'll start with what I've been thinking about for quite a while. When coronavirus arrives, what will be our reaction? The question is pertinent today because of the timing of this convention. It could not be more opportune for us to ask ourselves this, because in the next 2 days we'll be discussing the health sector in this country. And when the virus arrives, this is the sector that will be called upon to react. But let me remind you of two things. Cathay Pacific, that giant airline in Asia, in the last 2 weeks has had to reduce its fleet by 80%. Lufthansa is cutting its flight this week by 50%. The Americans are estimating that the airline industry is going to lose $113 billion. Italy has already quarantined 16 million people in the northern part, which is the most productive part of Italy. The ship cruise luxury industry is down on its knees. It's dead. Hotels are closing. Transport is dying. The government reaction from the economy standpoint has been, as the American federal reaction was, to reduce interest rates by 0.5%. The first time that the federal bank in the US is doing that as an emergency in nearly 50 years. But when they did so, the stock market crashed even further the day after. All these things are happening without a gun, without a bomb. There's no shot anywhere. People are reacting, and they're reacting to something that they can only imagine, because not very many of us can see a virus, even if you had a microscope. And it's bringing home something that many of us who've been in this sector for a long time, especially in this region, have been saying and saying so and will say so. Ignore this sector at your own peril. This sector is more important than the economy because it can bring the economy down. This sector is more important than the military because it can bring the military down. Yesterday, Sunday, churches in Italy, where Catholicism is strongest, were empty. We've seen in Iran, the mosques on Friday are empty. When they're empty, where do people go to? when people fall ill, where do they go to? They're supposed to run to hospitals. But one thing that you didn't know is that even hospitals get overwhelmed. In fact, the natural reaction usually is that people avoid places where a diagnosis has been made. So people will not go to hospitals because that will be a dangerous place. But remember too, that this epidemic also reduces the number of health workers. Already in Italy, 15% of the health workers in the affected area are themselves under quarantine. Because if I meet somebody who's diagnosed to be positive, then I'll be put under quarantine too. You start losing your health workers too. You lose the system. But here we are in Africa, still happy, still relatively protected because we've not seen anything. But it's not a question of if, it is a question of when. So when it arrives in Kenya, Governor Kuti, you're here, what will we say? I've had statements on how well prepared we are. Reminds me that the President of the United States, Donald Trump, said they were prepared. But now in the United States on its own, states are declaring emergency that they've never done since the World War. But here we haven't even declared that. We still allow health workers to go on strike. If there's one recommendation that we would like to make today, is that there should be a decree that there will be no strike, industrial action of health workers or anybody in health in Kenya for the next 3 months. Because everybody must be at their station at time of war. That would not be asking too much of us. If we did that, then we would have time to start focusing on why we are here today. And we're here today, as your program shows, to talk about this sector and the future of this sector and its preparedness to provide for Kenyans and non-Kenyans quality care. Both quality and care are constitutional rights in Kenya, so there is no argument about it. The only argument has been the definition of quality and the definition of care. The first statement that Kenya must accept in going on that path is that the future of healthcare is both public and private. So any effort, deliberate or accidental, that separates this sector into public and private in itself, defeating the purpose of providing universal health care. It is sad that in our pronouncements at higher and lower levels, we still want to separate these two and make it look like it's different. At the national level, at the county level. That's not happening yet. But that is not serving the public good that healthcare is supposed to give. It is serving individual ego and the kind of partitioning that is not good for the people of Kenya or the people of the region. So if Kenya wants to move to be at that hollowed position of providing care for its people and the people in the region and getting into medical tourism, that must be a national mandate. That in Kenya, healthcare is both public and private, and we start working together as one sector. But then let's step back and ask ourselves where we are today and why we are in this place in that sector. Modern healthcare in our region is just slightly over 100 years old. The first nurses produced in this region were at Mengo Hospital in 1919. So nursing in East Africa is 100 years old. It's interesting that this is also the year of the nurse. So the nurse ought to be at the forefront in everything that we do, because they were here before we started producing doctors. And as we look back and we see the growth of it, the most surprising thing is that every 10 years we have made the mistakes that we committed 30 years earlier. We have short memory. We have gone through free health care that promises people that when you come, care is there. It doesn't work. We have built institutions, Nyayo wards and everything, and asked women and children to come there. And they've come there, and care, if it has been there, it hasn't been quality. So how would you summarize, how would I summarize some of the challenges that this sector must face and must address if we are to get anywhere, leave alone contain coronavirus and many such pandemics that will join us? I'll point at 3, and I'll add another 2 to make it 5. The first one is that we must put our skilled human resource to work. Data show us that our skilled human resource in this part of the world are the least productive anywhere. We've seen data from the Ministry of Health talking about 60% absenteeism. When you are 60% absent, it means you are 40% present. And if that 40% presence is not with full attention, then it's probably 20% present. And this is true because it confirms the productivity of this sector, which we are now putting at somewhere between 30 and 20%. Any sector, any industry that's working at 20, 30% should close. No wonder in Africa today, when we go on strike, nobody bothers because they don't know the difference between when we are on strike and when we are working. So putting our human resource to work becomes, to me, a major, major priority. And for this country, it is particularly severe because we don't really have a shortage as such of human resource, but we have misuse of human resource. I'll give you 2 examples. Kenya, in East, Central, and Southern Africa, between South Sudan and Cape Town, if we look at nursing, the 2 countries with the biggest number of nurses are South Africa with 250,000 and Kenya with 100,000. The rest of the country, in fact, 90% of nurses in this region are in Kenya, South Africa, Tanzania, and Uganda. Uganda and Tanzania have about 60,000 each. But in this region, the country with the highest proportion of nurses who are not nursing is Kenya. Nearly 50% of our nurses are not in nursing. They have moved to other jobs because they are not respected as nurses. So even though we produce 10,000 nurses every year, we are unable to employ more than 1,000 every year. So where do the 9,000 go every year if you're producing them on your meager economy? That is misuse of a skilled human resource. The same will be said of doctors. The same will be said of laboratory people, physiotherapists, and others. In fact, this country in the region now has the most out of work medical interns in the region. They finish medical school, but they cannot even get the place to do their first year of internship. You have trained them for 5, 6 years, you paid for it, but you can't give them jobs. Instead, it has been politically correct to start employing community health workers because they are easy to deal with. They don't complain. They don't go on strike. So nurses out, community health workers in. Our nurses should be the first point of action, even in primary health care. But we are not even giving them those jobs. So we'd rather employ unskilled people. In global public health, unskilled people usually are used to fill the holes that the skilled people are not there to do. But for us, we push the skilled people out to the streets to sell airtime, and we get unskilled people to come, and we say we are going to provide quality health care. It will not happen. Let's handle the human resource crisis in this country and this region if we want this sector to grow. The second is corruption. The health sector is the most dishonest sector in this country and in this region. We are corrupt. I am corrupt. What people don't realize is that when you look at the range of public procurement in any country in Africa, the one sector that always ranks 1, 2, or 3 in terms of the volume of public procurement is the health sector. And that tells the whole story. That this sector is suffering from the weight of public procurement or misprocurement to the point that we are unable to buy anything and deliver it in time for the people who need it most at the cost at which they should. I don't have to go into this in detail. You know it. That is why today in Africa, we pay for essential medicine at 3 to 15 times what they pay for in India. And it's not because those things are manufactured in India. It is because we buy them more expensively, everything that is going to be there. So corruption must be eradicated from this sector if quality and sustainable healthcare is to be done. And that takes all of us. We steal from the sick in terms of their time. We steal on medication, buying it more expensively. We steal in equipment, buying it extremely expensively. And we steal from infrastructure. The most expensive real estate per square foot to build in East Africa and the rest of Africa is the floor in an operation theater room in a hospital. You cannot imagine what it costs, and yet it is just brick and mortar. Why are we building it so expensively? Why is it that it would be more expensive than somebody's luxury house? Because theater is not luxury. So corruption must go for this sector to have any way forward. The third challenge is a challenge of fear of innovation and lack of entrepreneurship. I'm 42 years old in this sector since I graduated, and I've never seen a sector that is more afraid of trying something new than this one. Even if it's just the use of a cell phone or a laptop. This sector cannot continue writing notes on the back of newspapers when we can now do it on IT. This sector cannot grow if we don't have data, if we don't have hospital records, and yet walk around the country and ask me how many hospitals have integrated IT system, which will cost much less than the paper that they write on. And you find that it's not there. In a country that moves every penny money on M-Pesa, data in hospitals, we cannot do. Innovation must be the mantra here. Not doing things the way we did it yesterday, but doing differently so that it works today. We could give you many examples in which doing things differently would make a whole difference to what it is. Those three areas, human resource, corruption, innovation, are central to our being able to move forward. Ignore them, and we will be moving backwards every year. But all that has to be put together under a different kind of governance. We still govern this sector based on the Public Health Act, which is more than 100 years ago British, where you have a management team that's made up of a medical officer of health and so on. In the era of public-private partnership, the health management team must be both public and private, because you need people who think beyond the next salary and people who think about sustainability. Those people are not in this sector at the moment. We have people who sit in hospitals because they are the CEO and they wait for money to come, but they cannot even focus on making NHIF claims. You have people who are sitting in offices thinking how to supply drugs, but they will not see that a supply chain without private sector involvement just doesn't work anymore. So thinking differently and a new type of governance is what we need. In my many years in this sector, this kind of conference has not taken place. It's always been a different kind of conference where we come in and present our small papers on what we've done. But what we need is a meeting that brings people together, because health does not belong to the health professional. Neither does health belong to the government. Health does not belong to the president. Neither does it belong to the governor. Did you know that this morning, the president of Portugal has just gone into quarantine for 14 days because over the weekend he was in the company of some kids and there was suspicion that one of the kids had coronavirus. So for 14 days, the president of Portugal will not be meeting anybody. It could happen to any of us. This is the importance of this sector that we must start looking at differently if we are going to move forward. I've talked of challenges, that I want to talk about opportunities. There is nowhere in the world where there is more opportunity to do good in the health sector than in Africa, because there's so much need, but so little supply. And in that area, I want to comment on one thing: the supply side of things and our preparation for the future that we want to see our country being a hub for medical tourism. The first thing we must ask ourselves is that what does a tourism want? A tourism is a person who makes a choice to go to some place to get something that they cannot get in their home area. They want security, they want safety. So security in health and safety in health is about the skills of the people in that country. So our institutions must produce skillful people, and our regulators must insist on the production of that. Yesterday's publication of the East African regulators on inspection of our 12 medical schools tells a story in itself, that there's lapses. The Nairobi University that produced me is no longer what it used to be. These are things that don't cost money. It takes determination for us to be able to move forward. Two, that we must be able not only to talk, but to walk the talk. And this comes in the area of corruption. We have identified areas of corruption, but we have not tackled them. Instead, we have brought excuses. Tell me, my country people, why would somebody buy a 40-foot container for 10 million shillings? We bought 1 billion worth of 40-foot containers, and they're still sitting somewhere, and I've not heard of anybody arrested. Why would you spend that kind of money on a container and get away with it? Two, we've heard of NHIF. I'm a big supporter of social health insurance. The problem is not social health insurance. The problem is the people we put there. If the money gets lost, who goes to jail? If this is a sector of action, then this sector must start showing that you do not get away with stealing from the sick. If stealing from the sick is allowed, then this sector cannot claim that it wants people to leave their countries to come here for healthcare. In this context, let me give you a bit of history. The cost of healthcare in Kenya is the highest in the region. Why? Even medicine that is manufactured in Kenya costs you less in Rwanda than it will cost you here. Despite that, why? These are questions of observation that anybody would want to ask and anybody would want to have an answer. Of the nearly 40 manufacturers of medicine in East Africa, 39 are in Kenya. And yet, we have not seen the advantage of manufacturing it. Two, let's look at the cost of healthcare. Why should cesarean section cost 30,000 and then cost 300,000 in the same country, with the same stitching, with the same surgeon? What is the factor that moves it from 30 to 300,000? Is it hotel accommodation? In that case, can I do it at Kempinski? Because the scale's the same. The stitches, the sutures, the knife, and everything is the same. The light, the water, and everything is the same. What are we paying for under those circumstances? Little known to most of you Kenyans is that the health system that we run in this country was never structured for the masses that we try to serve. Our health system, right from the beginning, pre-independence, was always an apartheid system. And the King George Hospital was part of the apartheid system, where you had the African side, you had the Rahemtula wing for Asians, and you had across the road the Nairobi Hospital, or what you call now for white people. As independence came, we allowed people to move, not because of color, but because of what they could afford. If I told you that the Nairobi Hospital is actually part of Kenyatta Hospital, would you believe it? If you didn't check, It is the same hospital. But at independence, something happened, and it was registered under something we call the Kenya Hospital Association. And since then, we've never slept easy. Ngong Road is a load of miracles. On one side of Ngong Road is a public hospital. On the other side is a private one. The public side is the Employment Bureau. It employs all the best consultants, best brains in the country. On the other side is a service area. That is where they don't employ anybody, but you go there for service. And that then is the miracle. That one day when we want to solve the problems of healthcare in Kenya, we'll go and sit on Ngong Road for 24 hours. Talk to patients, talk to consultants, and ask them what their experience is on either side of the road. That harsh nurse or consultant on Kenyatta side, when they cross the road and go to Nairobi side, they are the angel Gabriel at a cost. And this system is the one that is now driving healthcare in this country. Does it surprise you that the most expensive hospitals in Kenya are also not for profit? Think about it. The not-for-profit thing in treasury terms ought to be given to institutions that use their profit for public good. So look at that. What is the public good of the taxpayer in Kibera getting from these hospitals? If not, should they still be not for profit? The reason why that has to be solved is that the not-for-profit tag actually stifles competition. So investors in the hospital sector in Kenya find it very difficult to penetrate if you come in as commercial because you're competing with not-for-profits. And this is where the monopoly comes in, that we are unable to stretch ourselves to be able to cater for even the middle class because of this tag that was mistakenly given at that. Interestingly, we seem to be happy with it, and we think that that is a way forward. I'll finish by giving you one anecdote. I said that the cost of healthcare in Kenya is high, one of the highest in the region, but I'll also give you another thing. The driver of cost of health in Kenya is not the private sector. It is the public sector. Because when the public sector functions well, it brings in an affordable competition that the private sector then has to compete with. When the public sector is dead, then God forbid, the private sector is the only solution that we have. But let us ask ourselves what it costs to run the public sector. As I've told you before, building a public sector square foot is more expensive than building a private square foot. Buying X-ray equipment, CT scan public sector is more expensive than the private sector gets it, despite the fact that they buy volumes and should be benefiting from volumes. Medicines, public sector buys it more than the private sector. In other words, the vendor doesn't have to deal with the private sector in Kenya who is going to negotiate lowering of price. They will go to the public sector who will negotiate the increasing of price. This is the dynamics that is driving the cost of care in this country. And if we don't solve it, we shall be blaming the wrong person every time. The fault lines in this sector are not our human resource. It is a system of managing human resource. The fault line is not inadequate resources, it's the amount of leakage that happens in those resources. The fault line is not in the knowledge that we have, but advancing our knowledge to be innovative and be entrepreneurial. This is what India has done better than us. And India is offering a cost of care that you believe is quality, even when it is not. But it's cheaper than what we offer here, even after you've paid KQ to go to India. And there's a very simple business model that charge a little bit, but treat more people. So it's the numbers. And if you get that 5% charge on 1 million people, your profit is big. Ours is the opposite. Have exclusive hospitals that admit no more than 200 people and maximize on charging each one of them. And this is driven by our history, by our economic models, and by our structures. Unfortunately, none of you, not me, has been brave enough to point these things out. The solution is in our hands. But we do not want those solutions because the few people who control everything could not be questioned. I want this convention to be the beginning of that questioning. We are not a poor country of ignorant people who cannot treat anything. But we are a country that believes in hyperbole rather than facing the truth. Do not tell me that you are ready to handle coronavirus when you can't handle cholera. Cholera has been with us for how many years? And is spreading in every county. A county that can't handle cholera is highly unlikely they'll be able to handle coronavirus. So this conference must be the diminishing of hyperbole and the speaking of the facts. We are educated, we are intelligent, and we are forward-looking. Let's use the attributes for the benefit of this country. Only then can we start thinking of how to compete with India in the field of medical tourism. But even before we talk of India, let us also remember that internal medical tourism is also robbing the counties of considerable resources. Because everybody who is insured in Isiolo, the governor is here. When they are unwell, they'll want to come to Nairobi. So Isiolo facilities only treats people who are not insured. When they come to Nairobi, they buy food, they do everything else. So to me, internal tourism should be our first fight. That when people can be treated and assure that in their counties they have the quality of care that does not make them travel to come for a blood check in Nairobi. Only then can we think of stopping people from going to India. I thank the organizers for allowing me to share my thoughts.